and community partners really looking to serve the Medicaid clients across the 8 counties of Western New York. On behalf of the entire Millennium team, many of you who actually are here today, our lead entity, Erie County Medical Center, it's my great honor and pleasure to welcome you all to our first conference. Give me a hand. The Millennium Collaborative Care Population Health Conference. We've been planning this for quite a while. It's an educational and communications event. Part of what we're trying to do as a PPS to really help the community understand what's going on. We're probably the 4th or 5th PPS on this end of the state to do this kind of a conference. Since our founding in 2014, it's been our vision to bring together representatives from our partner organizations from all 8 counties: Allegheny, Cattaraugus, Chautauqua, Genesee, Orleans, Niagara, Wyoming, and Erie. Thank you all for being here from throughout Western New York. We can't thank and recognize our partners enough for being actively engaged with us in driving healthcare delivery across the critical areas, including acute care, ambulatory services, behavioral health, community engagement, and post-acute care. And as we have explored how to bring things together and bring this vision to reality, it became abundantly clear that nothing unites us all more, nor can do a better job than driving integration and understanding the whole population health concept. There is an emerging culture shift and outlook about healthcare in Western New York. The change begins based on 2 really important factors. The first factor is all people deserve quality health care. And the second factor is a person's zip code should not determine their health condition. Today, I'm looking forward to my own understanding of population health and to growing my own knowledge to rise tenfold thanks to an interactive presentation that we're all going to experience with Dr. Jonathan Burroughs here in a few minutes, one of the most foremost experts in the field who we're delighted to have with us today. Also, it's my pleasure to welcome New York State Medicaid Director Jason Helgerson, who will follow Dr. Burroughs a little bit later and bring us the latest on the future of Medicaid and DSRIP. Other special guests I'd also like to welcome and acknowledge include members of the Cerner Corporation, including James Canary, Senior Director, and Dane Sutherland, Senior Account Director of Cerner. I'd like to thank Cerner for their support and sponsorship of our conference today, and I'd like to invite you guys to learn more about our Healthy Intent Population Health Analytics platform enabled by Cerner under the guidance of John Phillips, our Millennium Director of Health Information Technology. I'd also like to extend a very special welcome and thanks also goes out to Ann Constantino, our board chair for Millennium, president and CEO of Horizon Health, and Allegra Jaros, the Millennium Board vice chair and president of Women's and Children's Hospital. Both Ann and Allegra will help us at the podium today. Dr. Francis Aluza of Rafa Family Medicine, also a Millennium Board member and the chair of the Physician Steering Committee, will also be part of today's event. She will be introducing our value-based payment panel, and that panel will include facilitator Ann Monroe. Ann Monroe is the co-chair of the New York State DSRIP Project Approval and Oversight Panel and former president of the Community Health Foundation. And our panelists for the value-based payment panel today will be Christine Blighty, Millennium's Network Chief Network Officer, Richard Braun, Senior Vice President of Finance and CFO of the Upper Allegheny Health System, and Ren Kieber, Vice President of Cope Health Solutions. I'd also like to welcome other various members of the Millennium Board of Managers and various other governance organizations within our PPS. I'd also like to thank President and CEO of Erie County Medical Center, Dr. Tom Crotoci. He will be closing us out later on with his remarks. So once again, thank you all for taking time out of your extremely busy schedules to devote most of your valuable time today to learn, engage, and continue to contribute to our ongoing DSRIP success. We've got a lot to do, guys. And to kick off the conference, I'm thrilled to introduce our Millennium Board Chair and President, CEO of Horizon Health, Ann Constantino, who will be introducing our guest speaker this morning. Thank you.
Good morning, everybody. So, it's a tremendous honor to introduce to you this morning's keynote speaker that I just met, Dr. Jonathan Burroughs. Dr. Burroughs it was first in his class at Johns Hopkins University with a 4.0 GPA, pretty good. You have your MD from Case Western Reserve University, and followed up a few decades later by an MBA with honors from the Eisenberg School of Management, Amherst College, where he again graduated first in his class, earning membership to the Beta Gamma Sigma National Business Honor Society. Dr. Burroughs has unparalleled achievements over a stellar 40-year career as a family practice resident, emergency physician, medical director, senior consultant, and president and CEO of a healthcare consulting network that bears his name. I just want to highlight a few of Dr. Burroughs' achievements over the years. Over 260 presentations and consulting engagements from Alaska to Florida and every state in between. 76 professional conferences attended and 42 legal cases testified in. 5 major awards, including an ACHE National Education Development Grant in 2014 with Dr. David Nash for creation of a new national 12-hour program on leading in a changing environment for population health. 66 published articles, blogs, and most recently the winner of the 2016 James A. Hamilton Award for Outstanding Healthcare Management book entitled Redesign the Medical Staff Model, a Collaborative Approach. Dr. Burroughs works with some of the nation's top healthcare consulting organizations to provide best practice solutions and training to healthcare organizations throughout the country. He is a recognized expert in the areas of governance, physician-hospital alignment strategies, and ways in which physicians and management can work together in new ways to solve quality, safety, operational, and financial challenges. Dr. Burroughs also serves on the national faculty of the American College of Healthcare Executives and the American Association for Physician Leadership, where he has been consistently rated as one of the top speakers, lucky us, and educators. And last but certainly not least, Dr. Burroughs' passion for the outdoors has led him to serve as a physician on mountaineering expeditions, and he has reached the summits of over 5,000 peaks throughout the United States, Mexico, South Africa, Europe, Africa, and Russia. And he is the co-editor of the 26th edition of the White Mountain Guide and the first edition of the Southern New Hampshire Trail Guide. Ladies and gentlemen, it is indeed a great privilege to have Jonathan H. Burroughs, MD, and President CEO of the Burroughs Healthcare Consulting Network here with us today. Please join me in welcoming Dr. Burroughs.
Thank you very much, Ann. Appreciate it. Thank you. Good morning, everyone. Is this on now? Very good. Good morning. Thank you so much for having me, and it's great to be part of an organization that's actually doing population health. Give yourselves a hand, folks. You know, it's amazing. Everyone says, oh, this is like the 90s. We've been through this managed care. This is all going to go away. It's going to be like a rubber band, and we're going to come back, and we'll go back to our comfy fee-for-service environment. We're going to crank out unnecessary procedures, and life will go on as usual. Well, it's not. I'm here to tell you that we reached the inflection point. This is what's called an industrial inflection. Every industry in the world goes through what's called a 100-year inflection, where every 100 years or so, the business model and the care model for an industry totally changes. And we are going through that right now, and you are all going to be the architects of that change. So you should feel very excited to be part of this new world. As Ann mentioned, in 2014, ACHE has a great program every year, American College of Healthcare Executives. They asked for development grants, and they said, here's the 3 topics we'd like you to compete for this year. We'd like you to either do population health, changing reimbursement models, or we'd like you to do emotional intelligence. Well, I disqualify from emotional intelligence. I can't do that stuff. I have a real bad habit of telling the truth, and that disqualifies me from any emotional intelligence course. But I said, I'll do the other two. And they said, well, you can pick one, but you can't pick two. I said, I can't talk about population health without talking about new reimbursement models. Because fee-for-service and population health do not go together. You cannot do them. So I thought to myself, now, people like David Nash are brilliant at talking about the academics of population health, but I wanted to learn how to do population health, which is different. So I used the grant money and I traveled around the country and I went to organizations that are doing population health to figure out what are they doing, what are they not doing, what works, what doesn't work, and they were very generous with their time. Because I'm a consultant, I use what I call the CASE method. Do you all know the CASE method? C-A-S-E, it means copy and steal everything. And that's what I do as a consultant. So what I do, you'll be glad to know that most organizations are not doing everything well. They do some things well. So what I did for this presentation is I plucked out the things the different organizations are doing really well and put it all together for you. And this is a 2-hour version of a 12-hour program that I'll be actually doing tomorrow in Hilton Head for the fellows of the American College of Healthcare Executives with Drew, who runs the master's program at Jefferson. So that's David Nash and I at a Chicago Bulls game. One time, how many of you like basketball? Sometime before you die, you should get a venture capitalist to give you 2 seats like David and I got. David said, do you want to go to a Bulls game? I said, sure, I'd love to. And so we go to pick up the tickets, and the tickets on the price of the ticket is $1,800. And the seat says CTS. You all know what CTS stands for? Courtside. So that's us at courtside at a Chicago Bulls game, holding the basketball during the timeout. And when you're on courtside, I understand why Jack Nicholson wanted courtside seats at the Lakers game. You are in the game. You are not watching the game, you're in the game, and the ball's actually going over your head as it's being passed. It's a different experience. You should probably do that one time in your life. So, let's start with the problem. We know this. We're ranked 37th in the world, according to the World Health Organization. Doctors hate. Any physicians here? Okay. I want you to know, any physicians, yes, and any executives here, some of you are going to be offended by part of what I'm going to say today. And that's why I do speaking and I don't do management. Because I tend to offend people. And I offend people by telling you the truth. And by the way, I'm not a futurist, I'm a presentist. I'm here to tell you the way it is today, not the way it's going to be tomorrow. So who wants to give me why we spend so much and get so little for what we spend? Anybody? What's the root cause of why we're 37th in the world and we spend twice as much as everybody else? Anybody? I'm sorry? Shuffling paper is part of it, but what's the root cause? That's approximate cause. There's a lot of ways. Exactly right, sir. Fee for service. Now let me explain. Whenever I see a complicated system in the United States, I like to play a little game called Follow the Money. Whenever you play the game Follow the Money, what appears irrational is actually quite rational and simple to follow. So, who decides that some doctors earn 4 times more than other doctors? Why does a neurosurgeon make 4 times more than a pediatrician? Are they that much smarter? Who makes the decision what doctors get paid? Anybody? Not the market. This is very highly regulated, what we do. Huh? Medicare is right. CMS, called MedPAC, Medicare Payment Advisory Commission, is a body that sets the rates for what physicians and hospitals get paid for what. Now, who oversees MedPAC? Who is MedPAC's boss? Congress is absolutely right. Congress is right. So who elects Congress? And please don't tell me the electorate. You'll make me very sad. Who actually elects Congress and the president, I might add? PAC dollars, that's exactly right. Lobbyists and PAC dollars. And if you don't believe me, go to the internet and see what everyone contributed to the campaign. And by the way, most corporations give to both parties with a very sophisticated scoring system of how they vote in Congress. So the Congress people actually work for the lobbyists, not vice versa. Leadership in Congress is actually an oxymoron. which means the people in Congress work for corporate interests. So you're absolutely right. What do people like Hewlett-Packard, Siemens, and GE want for the millions of dollars they're giving to get Congress people elected? What do they want in return for all that money? Reimbursement. They want a return on investment. And the return on investment is a high rate of return for their stuff, whatever their stuff is. So now, we don't like to think that we do this, but we have to play a game as we're getting squeezed called follow the money. And I'll give you an example. Do you all have centers of excellence? Yeah, I call centers of excellence centers of high margin, ancillary, and elective procedural revenue. Does anyone disagree with that characterization? That's what we're doing. We call it centers of excellence because that's what the public likes to hear, but it's centers of high margin revenue for us. That's why we do it. We play follow the money. That's why we do twice as many procedures as we need to in the United States. So we have a reimbursement system based on return on investment for stockholders and investors that has nothing to do with human outcomes. Think about that. We get paid for creating margin for suppliers, not for making people healthier. And that's a problem. We're the only country in the world that does that. Number two, we have this. Does anyone know what the third greatest cause of death and injury is in healthcare systems around the country today, behind cancer and heart disease? Anybody know number three? It's not behavioral health, but they're certainly very important. Medical errors. Over 750,000 people die every year from medical errors, and the root cause of that is what's called non-value-added variation and complexity. In other words, we've made our system so complicated, and we allow everyone to do everything their own way, that people make inevitable mistakes. And when they make mistakes, sometimes people get injured or died. And so we have this thing called non-value-added variation. Now, how many of you are putting in cost accounting systems so that you can measure the direct variable cost for every patient, every doctor's care of every patient in your facility? How many of you are putting in real cost, true cost accounting? Yeah, we have two hands here. The rest of you are going to raise your hand within the next year or two. Why do I say this? The natural variation in what doctors spend taking care of any patient is actually 1,000% or tenfold difference. And does anyone know which doctor tends to get the best outcomes, the lowest spending or the highest spending doctor? I'm sorry? More discharges. Well, yes, more discharges, but are they the lower or higher spending doctor? The lower. And if you want to read about this, get the Institute of Medicine report from 2012 called Better Care at Lower Cost. It turns out that doctors who spend less do something very old-fashioned. Does anyone know what that is? They think. Yes, they listen to their patients, they do a history and physical, and they think. They don't order tests. I mean, there are two types of doctors that I met in the world. There's the doctor who goes in, listens very carefully to the patient, does a great differential diagnosis, and cuts to the chase and gets right to the finish line. Other doctors say, admit, Mr. Brown, consult dermatology, consult cardiology, consult neurology, consult neurosurgery, and I'm going to go home and play golf now. And unfortunately, they drive up a lot of costs, and they get very poor outcomes because they end up chasing their own tail. So we have to eliminate this thing called non-value-added variation, which is a whole talk unto itself, but preserve value-added variation, which means physician and executive autonomy should always add value to human life, never detract from it. And professionals know the difference. The last little problem is that healthcare is bankrupting our country. Our national debt now is $20.1 trillion. That's our reported national debt. Our true national debt is actually between $65 and $85 trillion. Does anyone know why our true national debt is so much higher than our reported national debt? Why is our true national debt almost $100 trillion? Yes, unfunded liabilities in the form of statutory obligations in the form of Medicare, Medicaid, and Social Security. Now, I'll give you a little example. I am 67 years old. I'm on Medicare. I don't need Medicare, but I get Medicare. 3 years from now, I'm going to be getting paid $4,000 a month, actually, for the rest of my life. Money I don't need, but it is owed to me by the federal government. It's a statutory obligation. Does anyone know how we got to age 65 for the eligibility age for Medicare? I'm sorry? Life expectancy when? How about 1879? The first Social Security system in Western Europe was established by Otto von Bismarck and Kaiser von Wilhelm in 1879. And Otto von Bismarck went to his actuarials and said, give me the age at which only 3% of Germans are still alive. And at that time, it was age 70. Because Social Security was supposed to be an entitlement program for the elderly. The elderly. And so most Germans had died by the age of 70. He had to negotiate down to 65. When FDR created Social Security in the United States in 1935, he used Kaiser von Wilhelm and Otto von Bismarck's numbers. And when Lyndon Johnson and Wilbur Mills created HICFA, now CMS, in 1965, they used the same 1879 data. Does anyone know what percentage of Americans live till age 65 today? I'm sorry? 90%, actually a little lower, about 80%. 80% of Americans live to age 65, and once you get to age 65, your life expectancy is plus or minus 20 years, more for women, less for men. So we've created a Ponzi scheme whereby 20% of Americans support 80% of Americans for 25% of their lives. It's an economically unsustainable model that we have to fix. Now, simple solution. People like me would be willing to forego Medicare and Social Security until I'm in my 80s or 90s when I'm really going to need it, in exchange for better benefits. I would gladly give up my Medicare through my 60s and 70s, knowing that if I got to my 80s, they would cover long-term care, they would cover chronic conditions, and they would cover my deductibles, et cetera, et cetera. I'd be happy to do that, but no one in Congress is even offering that option to me. It's a take it or leave it, all or nothing. We've got to fix these problems. So this is the sad story. This is McGlynn. And McGlynn and the New England Journal of Medicine and the RAND Corporation have showed that 50% of what we do in healthcare is medically unnecessary, and 50% of what we should be doing has no reimbursement attached to it. How much do you get paid for not doing surgery or not doing a CAT scan? Hardly anything at all. And that's wrong, because sometimes that's the right thing to do. This is a chart you can't read. My wife always says, John, why do you have a slide nobody can read? And I tell her, because I explain it to people. So this is called the Preston curve. And Preston was an epidemiologist who demonstrated you get the greatest return for healthcare expenditures early on in the treatment. Now, this is per capita spending, and it's slightly older slides from 2013, so it only goes up to $9,000. It should go up to $10,000. And this is life expectancy. Now, over here is the United States of America. So not only do we spend twice as much as everybody else, we don't even live as long as everybody else. So why do we die earlier than all these countries that spend half as much money as we do? Why do we not live as long as all these other industrialized nations in the world? Anyone? Yes, it's how we spend our money. Lack of preventative care, he said. He's absolutely right. Now, let me give you an example. What are the two number 1 and 2 causes of heart disease? Smoking is number 1, and what's number 2? Obesity is number 2. That's exactly right. How much do you get paid treating smoking cessation and obesity? Almost zero. How much do you get paid for putting in stents and bypasses? A lot, because you're benefiting the suppliers. Cardiologists hate it when I say that. They hate it when I say that. We're paying for the wrong thing. We should be paying for smoking cessation and dietary control and treatment of obesity. And by the way, that, as Ann pointed out, requires behavioral health changes, because you have people who are depressed, bipolar, anxious, etc., who need that treated so they don't treat themselves with food. They're self-medicating themselves with food. That's what they're doing. And instead, we pay for stents and bypasses, and we create these great centers of excellence where we can do lots of stents and lots of bypasses. And that's why people die so young in America, because we're not treating the right stuff, because we're not paying for the right stuff. You get what you pay for, and we're paying for all the wrong stuff. This is one of my favorite slides. This slide demonstrates that only in the United States is death considered an optional activity. Every other country in the world, if you look at them, they pay a little bit more when you get towards the end of life, but not a lot more. The red line is the United States, and starting at age 53, we spend billions and billions more treating people who are dying. Does anyone know how much of someone's lifetime expenditures they spend in the last year of their life? Over half. Over half. And guess what? The last year of your life, you're going to die anyway. And interestingly, when Sarah Palin was given the catchword death panels when she was speaking out against Obamacare back in the 2008, 2010 elections, etc., anyone know who came up with that? The catchword was the manufacturer of ventilators, because dying in America is a $1 trillion industry. 40% of Americans die in hospitals, 20% die in ICUs, and they're going to die anyway. We spend all this money. My father, 3 years ago now, died at Brigham and Women's Hospital in Boston, Massachusetts. His family wasn't even there because he died at 4:30 in the morning, and he was in an intensive care unit with something that was an untreatable, uncurable condition, and he was almost 91 years of age. So it was a colossal waste of money and time. And we have to figure that out as a nation. Okay, so we have lots of waste in healthcare. Doctors are going to like this one. Executives are not going to like when I say this. We have $310 billion in inefficient delivery. This came from the IOM report in 2012. Does anyone know what the most inefficient thing that physicians and nurses do in their lives? Documentation is absolutely correct. Now, that will make physicians go, yes! And it will make executives give heartburn. I'm going to give you the very short explanation. When doctors are doing documentation, how much revenue are they generating for your organization? Zero. How much time, according to the AMA, do doctors spend doing non-revenue generating work? 50% plus. How much time, according to the American Nursing Association, do nurses spend doing non-revenue generating, non-productive work? 70 to 75%. So you're collecting no revenue when they're sitting at a computer terminal. How well do doctors do documentation? Terrible. And I say that, and I'm a physician. See, doctors are trained to document the primary problem. They are not trained to document comorbidities, which is what give it the level of acuity and complexity. The problem now with ICD-10 is that every disease has about 2 or 3 dozen codes, which means if you don't document all the comorbidities, you are leaving millions of dollars on the table. And then finally, 3, if you underdocument acuity, which almost every physician does, how are you going to score in your quality ratings, in your pay-for-value contracts? You're going to get dinged for quality because the payers are going to think that your patients aren't as sick as they really are. So what you need to do is get a whole cadre of scribes who are with clinical backgrounds, who are certified coders and have access to software. That is how you have to do your revenue cycle in the 21st century. That's all I'm going to say on that. But please, folks, get into the 21st century. Doctors should not be doing non-revenue generating work. They are too expensive to do that. You are wasting that resource. And by the way, that is the #1 cause of physician burnout. They did not sign up to become data enterers. That's not why they went to medical school. They went to medical school to be diagnosticians and to treat. See, doctors like some of my talk. They don't like all of it. They clap when I talk about documentation. They boo when I talk about non-value-added variation and standardization. You can't win all the time. Okay, now, who's driving healthcare transformation? Hint, this time it's not the insurance companies. Not the government. The government works for large corporate interests. Large corporate interests are driving healthcare transformation, which is why it's a done deal now. They run the country, if you haven't already figured that out. The government works for large corporate interests. And by the way, folks, lest you think that the government's gone to you-know-where, it's always been like that. It's always been like that. It was set up in the 1700s to support Caucasian male slaveholder landowners. That's why the government was set up, to protect their vested interests. Does anyone disagree with that offensive statement? Thank you. Right on, brother. So, see, that's why I'm not in management. I get to tell the truth as a speaker. So it was always set up that way. It was always set up to protect vested interests. Healthcare costs for large employers has gone up over 28% in the last 5 years, and they are done with it. They said if 36 other countries can do this better than we can, we demand that we do it as well. So large employers are running the show, and that's why we're never going to be turning back the clock ever again. So give up on that. The other problem is that healthcare is the #1 cause of personal bankruptcy in America. Now think about that. Healthcare costs are now 25% of total net family income. Now you've all heard the management term days cash on hand. Does anyone know what the average days, anyone not know what that term means? I just want to make sure. Okay. Does anyone know what the average days cash on hand is for the average American family? In other words, how many days without a paycheck will it be till the family becomes insolvent? And I'm including mortgage, savings, everything. 3 months. 3 months, 90 days. The average American family is 90 days away from complete bankruptcy. And the #1 cause of complete bankruptcy among employed Americans is health care. And the #1 diagnosis, anyone know what the top diagnosis is for bankrupting American families? Cancer. Cancer, you can spend up to $50,000 to $100,000 a year and out-of-pocket payments for every year you have cancer. And that can deplete your family in a nanosecond. So the American family is ready for healthcare transformation because they are sick and tired of having to do something they can no longer afford and that they need. So, the question is healthcare a product or is it something that everyone should have? And if you believe it's a product, like some people do in Washington, that means if you don't have the money, you don't deserve to have it and you deserve to die. If you consider it to be an entitlement, that means everyone deserves fundamental health care. And that's obviously a political question, but it's also a moral and ethical question as well. And by the way, 75% of health care spending is from chronic diseases now because we did a good job in the last century of turning life-threatening diseases into chronic diseases. Good for us. Now, this is the foundation of population health. A lot of people think population health, it's let's take better care of our communities. That is not population health. Population health is actually a misnomer. It should be called subpopulation health because what you're doing is identifying subpopulations and then finding out the optimum way of caring for them. Now, let me give you an example. This is Medicare. In every group of covered lives, there's the top 1% that makes up 23% of costs. And in Medicare, that's typically over $90,000 of expenditures every year for that person. The next group, these are people with life-threatening conditions. The next group is people with multiple chronic diseases. You know who they are, the smokers, people who are obese, they have liver disease, they have heart disease, they have lung disease. They make up 49% of healthcare costs, and they spend over $45,000 a year. Then you have the healthy 50%, which is most of the people in this room. I see my physician religiously every 5 years, and I bring him articles about why I'm not going to be taking statins for my high cholesterol and triglycerides. I'm sure my physician is edified by these visits and feels very satisfied with them. I have surgery every 60 years. I had a hernia fixed 2 years ago. Before that, I had a medically unnecessary tonsillectomy in 1954. Which I did not need. I had it at Boston Children's Hospital because everybody had their tonsils removed in those days. By the way, there was an era before then when every woman had a hysterectomy. That was considered birth control in those days. A nice progressive form of birth control. Let's just take everything out, including the ovaries. And, well, that was a good idea. So, the problem with the 20th century is what? How did we treat these four groups in the 20th century? This is the fundamental problem with healthcare in the 20th century. How do we treat each of those four subpopulation groups? The same. You had two choices. You could go to a doctor's office or you could go to a hospital. And we treated everyone the same. The problem with doing that is we spent way too much on the healthy 50% and not nearly enough on the top 5 and 6%. So in population health, what you have to do is identify these groups and provide the right care with the right resources for each of those groups, which means the bottom people don't need very much, the top people need the majority of the resources, and the second highest group need the second highest resources. That's population health. It's redistributing resources to those with the greatest need, not those who can afford to spend it. So population health is not taking better care of your community, it's rationalizing the resources to any group of covered lives. And that's what population health really is. Okay, so how many of you have ever read the book by Clay Christensen, a wonderful book, Jerry Weissman, and Jason Huang, called The Innovator's Prescription? No one's read it in this room? One hand. If you read one book about healthcare this year, I read books for a living. I mean, I write books for a living too, but I read books for a living. That's how I get to write. So this is my favorite healthcare book that I've read in the last 10 years. And that says a lot because I do a lot of reading. It's called The Innovator's Prescription by Clay Christensen from Harvard, the late Jerome Grossman, by the way, not Weissman, the late Jerome Grossman and Jason Huang. And they identify three major models of healthcare delivery. One is the solution shop. Now, I'll give you an example. I'm going to be a woman who wakes up one morning with a lump in my breast. Where do I go? My GYN. Isn't that interesting? We don't even call family doctor now. Oh, so you're going to be my GYN, okay? Okay, and you're going to palpate my breast, and you're going to discover a lump. And then you're going to charge me for that service, right? Ka-ching. Where are you going to send me?
I'm going to send you for a mammogram.
A mammogram. So you're going to be my radiologist, and you'll do a mammogram. But you're not going to give me the diagnosis, because that would be stepping on her toes, right? Right. Okay, but you're going to charge me for the mammogram, right? So you're going to, ka-ching, so you're going to tell me it's positive, ka-ching. Now where are you going to send me? For a biopsy. So you're going to be my general surgeon, and you're going to do a biopsy, and you're going to send that to your friend the pathologist, who I'd never get to meet, ka-ching, ka-ching. You're going to discover a positive lesion, but you're not going to want to step on her toes, so you'll send the results to her, and she'll tell me, you've got a positive lesion, ka-ching. So you better go back to your general surgeon to get a staging procedure. So you'll do a sentinel node biopsy, and you'll maybe do a PET scan and stage it for me. Ka-ching, you'll send the results to the pathologist. Ka-ching, ka-ching. And the radiologist gets to do the PET scan. Ka-ching. So then you'll send me back to her, and she'll say, you've got stage 3 adenocarcinoma of the breast. Where do I need to go now? Well, even before I go there, I have to go to a breast surgeon who's going to probably do a partial mastectomy or a lumpectomy or whatever they're going to do now, and they'll have to do some type of surgery and lymph node dissection, et cetera. So I'm going to go back to you, or maybe you'll send me to an oncology. You'll be a surgical oncologist, so maybe you'll do it, or maybe you'll do it as the certified breast surgeon, either, and you'll send all the samples to the pathologist, ka-ching, ka-ching, ka-ching. Then you'll go back and give me the results. Now you'll send me to an oncologist you'll be my oncologist. So I'll go over here, but you don't do radiation oncology, do you? So you'll go to your friend who does radiation oncology, ka-ching, ka-ching, you'll put me on chemo. You may give me some radiation or not, and then you'll send me back to my GYN. So how long in the United States does this whole process typically take, depending on where you live? Because if you live in a nice place like Buffalo, where all these specialists are within reach, that's one thing. Only on the other hand, if you live up in the northern part of New York State, north of the Adirondacks, you may have to travel distances to get all this care. So how long do you think, on average, this takes? Actually, it takes about 1 to 3 months if you're lucky, meaning the patient has the wherewithal to do all this, and if you don't slip information through the cracks. So the problem in the 20th century is we had this independent autonomous physician model where every doctor worked for themselves. Do doctors have any integration or alignment through joint contracts to be able to do this work together? Not typically. Do they share an integrated information network? Can they share information in real time with each other? Not typically. Is there a high probability of error with all these handoffs? Count on it. Count on it. And is there delay in diagnosis and treatment of a potentially life-threatening condition? Yes. Yes. And how are doctors paid and hospitals paid? Based on units of service by volume. So in other words, they get paid every time I have an encounter. So let's try it a little different way. And this is something the Mayo Clinic does better than anyone else in the world. I'm going to show up with a lump in my breast for the first time at the Mayo Clinic. How long will it take them to get an evidence-based diagnosis, prognosis, and treatment plan? 4 hours. Now, they do it a little differently. Who do you see when you go to the Mayo Clinic? Who do you see? You see a breast team. And all the people I've mentioned are on the breast team. And they have a clinical algorithm that they follow. And they have a pathway. And they follow this pathway. And everything's done. You come up NPO. In other words, you don't have anything to eat before you see them. So you're ready for potential procedure when you come to them. They give you all these instructions. And you come and you have every step we've talked about, only it's all packaged together. It's all packaged together. Now, they use an employment model, but you don't have to use an employment model. But all the doctors are aligned through some type of contract. They all used evidence-based approaches. They use IBM's Watson for decision support with this. Now, how are they paid? How are they paid for this service? Well, the doctors are paid. The doctors are actually on incentive there. They get a salary base plus incentive. But how is the Mayo Clinic paid? No, it's not just cash. They accept all insurances. But what's the payment model? It's a global bundled payment. And what are you paying for? The solution. You're paying for a solution. That's why in the book they call these solution shops. You come with an undifferentiated problem and you're buying a solution. In other words, I have a lump in my breast. I'm leaving with a diagnosis, prognosis, and treatment plan in 4 hours. What I am purchasing is a solution to my healthcare problem. That's why it's called the solution shop. Does that make sense? Okay. And it's less costly, it's more efficient, you get better outcomes, and much more likely that things will not fall through the cracks. How many of you are developing some type of model like this in any of your healthcare organizations, with bringing people together in a service line, standardizing care, having everyone paid under the same contract, and having an evidence-based approach to a life-threatening condition? Is anyone doing this? Okay, I see 3, 4 hands. This is something you're all going to be doing. Because the old day of seeing one doctor, then the next doctor, then the next doctor, then the next doctor, that is not a good system. It's expensive, it's cumbersome, it's too complicated, and things are likely to go wrong. And most importantly, you're delaying the diagnosis of a potentially life-threatening condition. Okay, so that's one thing. The next thing is, now we know someone has cancer or heart disease or needs major surgery or needs major treatment for a stroke. Do you want to go to some place where they see 5 of them, or someplace where they see 5,000 of them? Is there evidence in the literature that if you go to a regional center where they do lots of whatever they're doing, they have better outcomes at lower cost? Yes, there is, particularly for complex things. Now, for routine things, no. But for complex things, yes, like a Whipple procedure, like coronary artery bypass graft surgery, like esophagectomies, like pancreatectomies, like major oncologic surgery. There is ample evidence, and I'm involved in a legal case right now where a doctor did a Roux-en-Y procedure, which is a bypass procedure of the stomach. She killed the patient, 62 years of age, who had no other health care problems because she hadn't done the procedure in 12 years. Whereas 1 hour away, there was a hospital with doctors who had done hundreds of these procedures over the last year and was fellowship trained at minimally invasive techniques. So in the new world, we have to let the people who are going to get the best outcomes do the work. Now, in fee-for-service, we never wanted to do that because we're giving away our revenue. Again, we're being incentivized to make the wrong decision for the patient. We need to be incentivized to do what's best for the patient, not what's best for our operating margin. There, now I've offended some executives. See, and probably some physicians with that one. Now, how many of you still allow your doctors to use preference cards, where every doctor can have their own setup with their own instruments and do the procedure in their own way? Really, is that the truth? Well, good for you. Good for you, because that is a vestige of the 20th century. And the problem with letting every doctor do everything their own way was what? The likelihood of errors was very high, and the costs were very, very high. How many of you have your surgeons standardized all of their setups so that there's only one tray for any given procedure and one setup for any given procedure? So you haven't gotten there yet. You're on the journey. But you want your doctors to get together and standardize all of the most common things they do. It will improve outcomes, it will improve safety, and it will reduce your costs and optimize your outcomes. Organizations that are willing to do that are way ahead of the class. So what's going to happen in the 21st century is what's called focus factories. Focus factories is where you do something over and over again, you do it really, really well, and you do it as a team, and you refine it and refine it and refine it till you really do it well. How many of you have any form of focus factory in your organization? Okay, see one hand there. I'll give you an example of a focus factory. If you go to UCLA, Cedars-Sinai Hospital in Los Angeles, they have one team that does all the PICC lines, all the central lines, and all the arterial lines. And any doctor can volunteer to be part of that team. But if you go on the team, you have to do it one way. It's the bundle. You have to do it under sterile technique. They have a 0% complication rate, and they can do every one of those procedures in 8 minutes. And that's because they do it over and over and over and over again. And they do it really well. And the only way that a doctor can be allowed to put in one of those lines, except in a life-threatening condition, is by being part of that team. And if you want to get privileges to do that, you have to participate in that team for at least a period of time so you learn the right way to do it, and not the way you were trained 15 years ago. So that's a change in culture for everybody. How many of you have a value analysis committee where doctors and executives get together to not only pick what you're going to do and not do, but who your vendors are going to be? Folks, this is a best practice. I'll give you an example. Memorial Hermann Physician Integrated Group, the ACO, 1,800 doctors in Houston, Texas, put together a value analysis committee. And they standardized every single thing they did for all of their top 20 DRGs and every clinical specialty. They cut supply chain costs by $500 million in 3 years. This is huge. Physicians and executives should be making all vendor decisions together and making those decisions together and coming up with what is the most cost-effective fill-in-the-blank, stent, implant, whatever, for everything. Physicians have the clinical knowledge that executives don't have, and executives have the operational and financial knowledge that many physicians don't have. You've got to start working together on this stuff. Shouldice Hospital, by the way, is a hernia hospital up in Ontario, Canada, near Toronto, where all they do is hernias, and they can do them for $2,500, and they get great outcomes. Okay, chronic diseases. We are talking big, big, big numbers. Over half of all Americans have a chronic disease. I have high cholesterol and triglycerides that I inherited from my mother and my father. I had no choice. But a lot of people, 25% of people with chronic diseases, which is 12.5% of Americans, have chronic diseases that impact activities of daily living, or ADLs. So it's really significant. Hypertension's a big one. Heart attacks are still the #1 cause of death, but does anyone know what disease is going to take over as the #1 cause of death in America within the next 2 years? Cancer. Cancer is going to be #1, and right now cancer is #1 in 27 states. So cancer is going to be #1. Heart disease is actually coming down. Cancer is going up. as we living longer, et cetera, et cetera. So heart disease, 80% of heart disease is preventable. Now, only 20% of Americans smoke, but where are these Americans who smoke most concentrated? Poor neighborhoods and rural areas. And you'll go to inner city neighborhoods where you have a 40 or 50% smoking rate, both among kids and adults, particularly among poverty. And why are they smoking? They're self-medicating themselves for depression. They're angry and depressed, and they're smoking to self-medicate themselves so they feel better about their lives. And they're killing themselves by doing that. 33% of Americans are obese. We're number 2 in the world, right behind Mexico. Go America. And people are overeating to self-medicate themselves for anxiety, depression, bipolar disorder. That's why they're eating, to medicate themselves with food. We have 5 times the expected amount of diabetes that we should have. Why? We are addicted to sugar. We love sugar in everything. We put sugar in our ketchup. We put sugar in our relish. We feed our kids sugar through all these sugar cereals, and we think we're making them happy. We're not making them happy. We're making them addicted to sugar. We have to stop doing that. We have soda, that's sugar water. And the problem with sugar is not only is it empty calories, but more importantly, it allows your body to release insulin, so you think you're hungry when you're not hungry. Your body can't shut off its hunger, so you keep eating even when you're no longer hungry because your blood sugar's low, because your insulin's just peaked and come down. So it's very simple. We're making people addicted to food and addicted to sugar because we're not treating their behavioral disorder. And 20% of Americans smoke. So what the team at Harvard feels is what do people with chronic diseases really need beyond a doctor and nurse? And by the way, they don't need a doctor and nurse as much as they need this. Any of you have any family members with alcoholism? My mom's an alcoholic. Where does my mom go every single Sunday, religiously? AA. That's exactly right. She's been to AA every Sunday for the last 55. That is her church. That is her church. That is her spiritual life. And she helps younger people deal with alcoholism and the ravages of alcoholism. What people with chronic diseases need is other people with the same chronic disease so they can figure it out together. It turns out most people make 99.99% of decisions about their chronic disease themselves, not because of what their doctor tells them. And they want to learn from other people with the same chronic disease how to get over or kick the habit, and that's called a facilitated network. And by the way, the business model is based on facilitated membership, and it relies heavily on behavioral modification. If you don't treat the behavioral problem, you will never cure the chronic disease. The root cause behind smoking is behavioral disease. The root cause behind people with cirrhosis is behavioral disease, and alcoholism, and drug addiction, and opioid addiction. People are taking opioids because they're treating a behavioral condition, and that's why they are addicted to opioids. Everyone's going to be disrupted in the 21st century. First of all, 40% of hospital capacity is going to go away. Why is it going to go away? Where are people going to get most of their care in the 21st century? Not urgent care. Where are they going to get most of their care? Not at the drugstore. Where the internet is getting warmer. Home. Most people are going to get most of their health care at home on their smartphones. That's where most care is going to take place. This is going to offend some people, who haven't I offended yet. I have 2 kids in their 30s. My daughter's going to turn 40 in 2 months. And they do not have a personal physician. They have an app. And they can access a doctor in 2 minutes on their app 24/7 for $49. Now, obviously, it doesn't work for complicated stuff. They have to see a real doctor in person. But the point is, most people don't have life-threatening things. Most people have routine things. And how many of you have ever gotten health care on your smartphone through an app? I don't believe this. I see one hand. The reason I say I don't believe this, does anyone know, out of a population of 345 million in our country, how many Americans last year got health care through an app, through a kiosk, through their employer, or through some type of smartphone? 100 million. hate to say it, folks, you're behind the times on this. This is where people are going to get their health care. And my son will tell you, if you don't have an app, you're not even in business for the millennials. My son doesn't have a laptop anymore. He has a device. He has a phone. And he does all of his shopping, all of his business, and all of his health care on his device. And if you're not on a device, you're not even giving health care services out. Not to healthy people anyway. Maybe to sick people you are, but not to healthy people. So hospitals are going to be disrupted by retail outlets, minute clinics, and e-health. Physicians, we're not going to need as many doctors in the 21st century. Why are we not going to? Everyone talks about the physician shortage. There is no physician shortage. There's physician mal-deployment. Why are we not going to need as many physicians in the 21st century? This typically offends doctors. I apologize to you, doctor. Who can give 90% of the care for high-volume, low-risk conditions? Nurse practitioners and PAs and e-health providers. So what's going to be the role of the physician in the 21st century? You folks are going to be clinical executives, and you're going to be overseeing other people providing routine work, and you're going to be doing the complex stuff. You're going to be doing the more complicated stuff. And I'll give you an example. My stepfather actually figured this out in the 1980s and 90s. He was way ahead of his time. He was the first OBGYN in York, Pennsylvania. And he hired nurse midwives to do what? All of his routine deliveries. He hired GYN, advanced practice nurses, to do what? All of his routine office works. What did he do? He did cesarean sections, high-risk pregnancies, and colposcopy in the office, and he managed the practice. He didn't see 30 people a day in the office. He saw 150 people a day in the office. And he was responsible for all of it. That's called being a clinical executive. Doctors are not going to be doing piecework in the 21st century. They can do piecework, but they're going to get paid at the level of an APN or PA if they do that. They'll get paid for their leadership and to be clinical executives, and they'll make a lot of money doing that because they'll be paid 7 figures to do that, not what they're paid now to do piecework. Piecework is an inefficient form of healthcare delivery. Doctors don't like hearing that, but that's the fact. Now, we're in competition with the world. I'm not going to talk that much about medical tourism, except to say that people will go anywhere in the world that they can get low-cost, high-quality care. And last year, 1.6 million Americans left the United States to go anywhere else where they could get life-saving health care. And I'll give you an example. Anyone know where the cancer treatment center of the world is right now? Cuba. Well, Cuba's way up there, but the #1 center right now is Frankfurt, Germany. And you can ask Lufthansa if you don't believe me. The reason is that chemotherapy costs 90% less in Germany than it does in the United States. And so people with life-threatening conditions and high deductible policies are going to Germany to get their cancer treated so they don't have to bankrupt their families. That is a problem that we have to fix. Next one. Insurance companies know they're getting put out of business. What is every sophisticated healthcare system doing today about insurance? They're vertically integrating it through captive insurance plans. Almost every large healthcare system that I'm working with is now coming up with their own insurance product or their own health plan. Now, they don't have to necessarily manage it, but they will at least have partial ownership of it. And that is a new skill and a new competency that healthcare executives have to have. They have to learn how to manage actuarial risk. And by the way, there are people who are already expert in that you should learn from to do that. So you're not going to have Blue Cross and Blue Shield just sitting out there managing you. You're going to be integrating your own insurance plan. And I'll give you an example of that. St. Luke's in Boise, Idaho, was tired of getting you-know-what by Blue Cross and Blue Shield, so it went to Select Health in Intermountain in Salt Lake City and signed an exclusive agreement, and they have their own captive insurance plan. And last year, St. Luke's captured all the 100,000 lives of government employees in the state of Idaho, and they now own those covered lives. Blue Cross and Blue Shield was so teed off that they sued. They were responsible for the antitrust suit against St. Luke's, which they lost. And my friend David Pate, who's CEO of St. Luke's, said, well, we lost the battle, but we won the war. Because Blue Cross and Blue Shield no longer runs our state. And that's what people are doing. They're taking back control, eliminating the middleman, eliminating the overhead cost of the middleman, and now they're going to do it themselves. But that's a new competency, and you have to humble yourself that this is not something we were trained to do. We have to learn to do that from others. Next one, low-end to high-end disruption. I haven't talked about disruptive innovation. I'll cover that very briefly. A lot of people think disruptive innovation is when new kids on the block come on with crazy, wacky ideas and they take over. No, that's not how disruption works. Disruptive innovation that you've heard from Clay Christensen is really when we abandon the low end of our own industry. And as we get squeezed financially, we're drawn to higher and higher margin stuff. We don't do preventative health care. There's no money in it. We don't like taking care of the poor. There's no money on it. We don't like treating chronic back pain. There's no money in it. We don't like treating chronic behavioral conditions. There's no money in it. So we abandon that part of the industry and we focus on stents and bypasses and implants and all the stuff that makes money. What happens when people abandon part of their own industry? Well, it doesn't just figure out how to survive. What happens? Someone else takes it over for us. Someone else is a new entrant, and they come in and said, we know how to do that better than you know how to do that, so we're going to take it over. So Walmart and CVS and Walgreens come in, and they take care of all of our urgent care among people with cash and insurances. And we said, oh, we don't care about that. Let them have urgent care. There's not a lot of money in urgent care anyway. Then they figure out, well, why don't we start doing surgery here and do a surgery center, et cetera. And Walmart now has Talk-A-Doc, where you can get a physician visit as part of the nurse practitioner visit. And what happens is they come up the little chain, the food chain, until they start eating your lunch. And I'll give you an example of that. The pharmaceutical industry used to outsource R&D, research and development, and the people who were coming up with a new product said, wait a minute, that's the hard part. We can do manufacturing and distribution and marketing. That's the easy part. And then they take over the whole thing. And they're decimating the giants who outsource the wrong side of their own industry. So beware of disruptors, because you think, well, they don't really matter now, but then they start eating your lunch. And they take away all the profitable part of your business because they know how to do it. So that's what disruptive innovation really is, low-end to high-end disruption. Centralized to decentralized. Where did most of their people get health care in the 20th century? 20th century, last century. Doctor's office or hospital. Where are they going to get it in the 21st century? Home. We're going full circle back to the 19th century, only this time we're going to have wireless tools and technology. How many of you in home health are using wireless technology so that you can monitor a patient without actually physically being with your patient and get decision alerts so that if the hemoglobin A1C is going up, the blood pressure is going up, the oxygenation is going down, and the O2 sat's going down, you get an alert through your smartphone or through some central monitoring device so you can go to the home and do an intervention. This is home health of the 21st century, and this is how organizations all around the country are beginning to do it. So, home-based telemonitoring, wireless care. Patient and consumer-centered. When I say consumer-centered, I mean patients are going to run healthcare. If you want to read about that, read a book by Eric Topol called The Patient Will See You Now, or The Creative Destruction of Healthcare, or Medicine. And basically, people are going to be managing their own healthcare, and physicians and hospitals are going to be considered commodities. And they're going to control everything, just like in the banking industry. Do you all remember banking in the 20th century? Any of you old enough to remember when you had a bank book, and in order to make a deposit or withdrawal, you had to take your bank book to your banker during banking hours to get them to stamp your book so that you could get your cash? Well, guess what? We don't need those people anymore. But that's how we still run healthcare. In order to get a doctor's note, you have to make an appointment to a doctor's office, sit in the waiting room to see a doctor for 5 minutes, spend a lot of money for a note. It was just like the banking industry 50 years ago. Well, we are not going to be doing it that way in the 21st century because we don't have the time and the money to do it that way. So it's going to be driven with 24/7 on-demand access. So how many of you in your organizations are creating some way that people can get low-cost, 24/7 health care on a smartphone through your organization? I see one hand. Folks, you can put this in tomorrow. You can put this in tomorrow. And if you don't have the capital to invest in it, the platform's happy to run everything for you, even give you the doctors and give you the platform and all that. You can do it tomorrow for free. Now, you won't get to keep any of the revenue if you do it that way. But people, you've got to think about investing in this. Millennials now make up 50% of the total economy. Well, that's only 50%. We can focus on the other stuff, right? So we have to be doing this. So let's go back to population health. You want segmented services for different populations. Healthy people, what do people like us in the room need? We need a smartphone. We need an app. And we need retail clinics. There's going to be 50,000 of them worldwide within 3 years. If we need to go to an emergency room. If I need to get a laceration, do I want to go to an ER where I'll wait 3 hours and spend $600? Or do I want to go make an appointment and get it done for $49 with an advanced practice nurse? Your call. See, I call retail medicine EDs for healthy people. And they take Medicaid, they take all coverages. So this is the healthy place to go when you don't want to sit in line and you don't want to pay an exorbitant fee. Individuals with chronic conditions, they need disease management. We'll talk about that with facilitated networks and home-based telehealth. Individuals with complex undiagnosed problem need a solution shop, like I mentioned earlier. Individuals with significant chronic conditions need evidence-based focused factories. Talked about that. Terminally ill people need outpatient palliative care at home. Both of my in-laws died at home, and I plan on dying at home. I am not going to be dying in an ICU. It's a waste of my time and my money and my family's money as well. So we're going to talk now about the operational building blocks of population health. So number one, you cannot do population health without this. Engaged and aligned stakeholders with at-risk contracts. I recently got fired from giving a talk in Oregon, Bend, Oregon, to an IPA, Individual Practice Association. And they said, we went through your slides and we don't want you to come and talk to us. And I said, what about my slides offended you, if not all of them? And they said, well, our model is we want to remain independent and we want to do population health ourselves without working with the hospital, without working with home health, without working with skilled nursing facilities, without working with long-term care facilities. And I said, it cannot be done. I said, the two are mutually exclusive. You cannot do population health and remain as an independent, isolated organization. You have to work within an integrated delivery network of some kind with at-risk contracts. They said, well, we'll get another speaker then because we want to hear a different message. I said, fine, listen to whatever you want. It's not going to change anything. I'm just a messenger. These are not my opinions. These are things that I have observed around the world. I'm not here to give you my personal opinion about anything. I'm here to be a messenger as a conduit so that you know what lots of other people are doing. How many of you are working to align with every physician on your staff, whether they are self-employed or employed? Okay, that should be your number one strategic goal for this year. If you have unaligned physicians, you cannot do any of this. Just forget it. Forget it. You will not be able to do any of this. You have to start paying doctors differently. You have to pay for outcomes, and you cannot do that if they're not aligned. And I will show you how to do that in a minute. Okay. Come on. Number two, you're going to have to build an integrated network together. Why do I say you have to build the network together? You can't build a network independent of input from the skilled nursing facility or independent of input from the long-term care facility or whatever facility. Why do you have to do this together? Because they know their business better than you know their business. And they're experts in what they do. And we have to humble ourselves to the fact that everybody else is better at what they do. We know what we do. And we do what we do really well. They know what they do better than we know. And so we have to build a network that makes sense for everybody, not just for the hospital. And by the way, there are going to be no more standalone hospitals in the 21st century. Hospital is going to be a cost center in a clinical integrated delivery center with some type of capitated or global services payment. Hospitals where you're going to want to keep people out of, not fill beds. That whole notion of filling beds is going to be a cost to you, not revenue to you in the 21st century. So you have to think of hospitalization as a bad thing that you want to avoid at all cost. And by the way, doctors' offices and ED visits, the same thing. You want to avoid as many of those visits as you possibly can. 3, I'm going to talk to you about palliative care, disease management, post-acute care, disease management, retail medicine, and e-health. And by the way, you want to put this stuff in that order. And I will explain why you want to put that stuff in that order, but I'll explain what each of those things are over the next hour. And you have to link it all together through a health information exchange, or HIE, with enterprise data warehouse and clinical and business analytics. Analytics is different than data. How does analytics differ from data? Anybody? What's the difference between analytics and data? Data is the 20th century. Analytics is the 21st century. Analytics turns data into actionable information you need to do your job in real time. And you can also predict what you need to do in real time through predictive analytics. So what happens is all this data that we are flooded with in our lives goes through the sausage grinder, which is how I describe the enterprise data warehouse. And the enterprise data warehouse takes all that data in, zip code, non-clinical determinants, your socioeconomic stuff, all your medical stuff, your financial stuff, your legal stuff, your demographic stuff, and it scrambles all in together and spits out the information you need to do your job in real time. It's actionable information, and everybody needs different information to do their job. So you have to do all 5 of these things to build population health. So let's go back to the first one. Now, people say, so John, what is engagement and alignment? It's real simple. Engagement is ownership. Alignment is self-interest. If you want to engage with doctors, doctors have to be able to say, this is my organization that I manage along with executives, and I have ownership in this organization. If they can't say that, they are not engaged. And you can do all the engagement surveys you want from all these organizations that make lots of money doing engagement surveys. It will not teach you anything. It will not teach you anything about engagement, because what engagement is this is my money, my patients, and my organization. If a physician cannot tell you that, they are unengaged. And I don't care what parties you give them and flowers you give them and Doctor's Day you give them. They are not engaged. Physicians were engaged when they owned their own practices because it was their practice. That's engagement. Ownership is engagement. Engagement is ownership. Alignment means they are being paid to do the right thing for patients, and it's in their self-interest to do that. It's in a surgeon's self-interest not to operate on the hip, because physical medicine and rehab would provide a better outcome, lower cost effectiveness. How many of you pay your doctors the same whether they operate or don't operate? See, that is the tragedy of work RVUs. Doctors are only paid when they operate. And if they don't operate, they're losing money. That is unalignment. In fact, that is what I call a negative alignment or perverse alignment, where you're actually paying them to do medically unnecessary things. And you're paying yourselves to do medically unnecessary things because it's good to your bottom line. And I see organizations all over the country doing unnecessary stenting, unnecessary spine surgery, unnecessary fill in the blank, because you're financially rewarded for doing so. And that's wrong. And you need to stop doing that. The only way you can do that is to voluntarily get out of fee-for-service. Yes, I said voluntarily. Not because you have to, because it's the right thing to do. But you want to make money doing it the right way. I didn't say you shouldn't make money. You should make lots of money. In fact, the best organizations in the country are making lots of money doing the right thing. You do not want to make your money doing the wrong thing. You want to make it doing the right thing. There, I've probably offended now everybody in the room with that last statement. So, cultural alignment, the relationship precedes economic alignment, the contract precedes clinical alignment. Let me go back. Come on. Okay. If a doctor tells you, I hate the 21st century. I don't like working in teams. I throw up every time I think of the word team. I don't like working with management. They're all dorks. I don't like working with nurses. They're inferior. I don't like standardizing my practices. I don't like using technology. And I certainly don't like cookbook medicine. What do you know about their potential for alignment? We are not going to the prom together. What do you need to say to those doctors? Goodbye. We wish you all the best. By the way, please do not feel sorry to say goodbye to a doctor. They can make a handsome livelihood working on their own. They need to be working on their own, where they can be the boss, and it's between them and their patients. Some doctors were not put on earth to follow any rules or algorithms. I get that, and I've told many doctors in my consulting career, you should work for yourself. You don't like following anybody but a higher power, yourself and your patient. Great. Go and be happy. And there's places in the world for people who can provide concierge practices where they can do it exactly the way they want, or they can do direct primary care, or they can do lots of things on their own. Yes, they'll have to take full responsibility for the capitalization and all that stuff, but God bless them. Okay. Number two, not every doctor wants to be employed or needs to be employed. You can have lots of ways to contract with doctors or any other organization, like co-management agreements, etc. And then everybody needs to go at risk. They should be paid proportionally on how much accountability they're willing to assume for both clinical and business outcomes. And that's how you want to work with people in the 21st century. Now, I will tell you a little story about Paul Convery, the former first chief medical officer for Baylor Healthcare System in Dallas, Texas. Now, we have one doctor. What's your specialty, ma'am?
I'm internal medicine.
Internal medicine. Well, I'd like you to channel, for a moment, a very narcissistic, charismatic orthopedic surgeon. Can you do that? You know what I'm talking about. Yes, okay. So basically, Paul was hired from SSM Healthcare by Joel Allison, who's one of my favorite CEOs in the country, who retired in February, unfortunately. One of the great CEOs in the United States. And he said, Paul, there's 1,800 fat and happy, independent, self-employed surgical specialists who are all making over $500,000 a year, and I want you to get them within the Baylor team. Can you figure out how to do that? So, Paul had an ingenious idea. He formed an MSO, a management services organization, which is basically a contracting entity for Baylor. And he went to the doctors and had a conversation like this. Your first name is? Kenyani. Kenyani, now can you channel just unreasonable aggression? Okay, good. This has to be unreasonable aggression. Okay, Kenyani, I want to thank you for allowing me the opportunity to audit your practice and to speak to you. I'd like to talk to you about how you can earn more money, have greater control, increase the value of your practice by working with Baylor. Would you be willing to have that conversation?
For what?
So that you can do better financially, and instead of making the high six figures that I've seen you make, we can get you up over 7 figures. Would you be interested in talking about that?
How long does that take?
Not long at all.
I don't have time for this. Is there?
Okay, well, nice talking with you. Okay, you have to be a little less. I know, but at least be willing to have the conversation, okay?
Okay, I'm willing to.
Okay, so we're going to have the conversation. Now, are you aware that basically we have contracts, we have leveraged contracts at Baylor that we could help you get paid 15 to 20% more for everything you already do? Are you aware that if you became part of our organization, you could get paid more for every single thing you do?
Paid more.
Yes, and here's why. We're a $4.8 billion system. You're a $2 million practice. But see, we get leveraged contracts that you don't have access to, so you would have access to those contracts. Would you be interested in that?
Now I'm listening.
Okay. Now, would you be interested in getting access to our GPO, which is our group purchasing organization? We can get all of your supplies. We've already done the calculation. We can help save you 12 to 15% on all your overhead costs for your practice, so you'll be able to keep more of that in your own pocket at the end of the year. Would that be of interest to you?
So I can keep 12 to 15%.
More, yes, because we can help purchase this stuff we can lower your overhead costs by at least 12%.
Okay.
Okay. Would you be interested in getting access to, through high tech, we can put Epic or Cerner into your office. And the reason why that's important is that we want you to become part of our narrow networks, which means we want large employers to send you orthopedic patients. But we can only do that if we can report out your quality and cost analytics to the payers and to the employers so they can see what a good doctor you are. And then they can send you preferential referrals under those agreements. Is that something you'd be willing? And by the way, when you go to sell your practice one day, having all this IT, sophisticated IT, which we're going to spend 85% to invest in, is going to increase the valuation of your practice when you finally go to sell it. Would that be of interest to you?
So I'll make more money.
Yes.
Okay.
Yes. Sometimes you have to connect the dots for these orthopedists. Now, in order to do this legally, we would have to take over your revenue cycle, which means we'd have to do your billing, coding, and collections. But here's the deal. We've already done an analysis of your revenue cycle, and we can guarantee you contractually that although you'll have to pay us for that revenue cycle, so we don't violate Stark or anti-kickback, you'll get a net 11% increase return on every clean claim, because we do this really well, and we have a whole system down in Dallas, downtown Dallas, that does this. And so you can do better. In other words, in order for you to access these payer agreements, we would actually have to take over ownership of your revenue cycle, although you would still maintain complete control and self-employment of your own practice.
So control, I'll have that.
Yes.
And I can make more money.
Yes. Okay, are we good? We're good. Okay. Would you like access to investment capital? We're a AA bond rated organization, and our cost of capital is a lot less than yours. So if you want to expand your practice, bring in new partners, build a surgery center, we'd love to be an off-balance sheet partner for that. We could put up collateral for you, and you could maintain majority ownership of that, but we would help you capitalize any of this. We could get you capital at a much lower cost than you could get on your own.
So I still have autonomy.
Yes.
And I can make more money.
Yes.
Okay.
Okay. Now, come on. This thing's a little... Okay. Now, we can get you access to preferential referrals, and if you're interested, we can give you a leadership role, and we'd be willing to pay you pretty top dollar if you can help us to achieve top outcomes in the orthopedic service line. Now, you don't have to do the leadership, but if you're interested in leadership, we'd be happy to talk to you more about that. Now, as you can probably guess, there's some non-negotiables I need to talk to you about, okay? These are things that we don't have wiggle room on. And here's what they are. Number one, come on. Are you willing to work with us to standardize regulatory quality? Now, what that means is, under our bundle payment contracts in orthopedics, we have certain metrics that we have to meet. And if we meet them, we get paid. And frankly, if we meet them, you'll get paid even more. So are you willing to standardize some of your clinical practices, standardize the vendors for implants, et cetera, so we can hit these payment contracts out of the park and we can pay you at the top rate?
Sounds reasonable.
Okay. Number two, would you be willing to work with management to drive down operating costs? We have a value analysis committee. We'd like you to participate on that, but we'll have a gain sharing arrangement so that for every dollar you help us spend, we'll turn and invest half of that back into your practice, which will again increase the value of your practice. Would that be something you'd be willing to do?
That also sounds reasonable.
Okay, and finally, number three, we'd like you to work with us to achieve strategic goals and objectives around population health, service and culture, et cetera, et cetera. So is that something?
Yes.
Okay, a big round of applause, please, for my orthopedic surgeon. Very good. You do that very well. Now, if you go to Intermountain, every doctor, whether they're employed or self-employed on the medical staff, has to sign these non-negotiables. Number one, be willing to participate in at-risk contracts based on goals and objectives developed and approved by physicians and management. Number two, comply with clinical and business best practices determined by peer group and management, and be willing to be peer audited for exceptions. Number three, agree to unblinded transparency. Everybody at Intermountain can see how everybody's doing in every aspect of the organization, unblinded. Every doctor, every nurse, every employee, and every executive, including the CEO. Everybody knows what everyone's getting paid, everybody knows what everyone's being measured on, and everybody knows who the high, middle, and low performers are. Welcome to the 21st century. What does that do to performance when everybody knows that everyone can see? It increases it for everybody. That's how it works. Be willing to comply with value analysis process. That means if an orthopedist or neurosurgeon has an equity relationship with a vendor, but the organization says we are not going to use your preferred implant or stent or whatever, you have no choice. Your only choice is either not to use it or to leave. Those are your two choices. And finally, disclose all potential conflicts of interest. Every executive, every nurse, every physician with any type of business relationship in any kind of health-related things need to disclose that to everybody to determine if that will undermine and create any conflicts of interest in terms of clinical decision-making. So, organizations now are starting to have non-negotiables. Why are doctors willing to sign on? Because they can do a lot better with the organization than they can on their own. Okay, welcome to the new hospital. Hint, it's not a hospital anymore. It starts with the person's home, and then it goes to the schools. Why are schools part of population health? That's where kids get fat. That's where they sit all day, they don't have any physical education, that's where they eat junk food, et cetera, et cetera. You need to have a contract with the schools. Why? Because you're going to be paid based upon the outcomes of those kids and their parents through your employee health plan. Think about that. Everything's connected to everything in the 21st century. Care team, access clinics, diagnostic centers, procedure centers. Oh yeah, the hospital. Post-acute care, patient home. You have to build a network that contracts with all of these entities in order to build an integrated healthcare delivery system. So, remember I told you the top 1%. They need palliative care. I'm going to talk about palliative care in just a moment. Palliative care is not hospice care. Palliative care is actually a bad word. I think it should be intense disease management or some other description. Palliative care is a terrible description. Who would like to describe for me what palliative care is? Anybody? Any of you working in palliative care? Nobody? Okay. Can you define it?
It's not hospice.
It's not hospice.
Complex care management, really, at the end of life.
But it's not end of life. See,
You're right, toward the end of life.
it's not even toward the end of life. It's people with life-threatening conditions.
Yes.
That's different. Palliative care is not about end of life. It is about optimizing life for people in the top 1% of costs and risk. Okay, this is what you give people who are in the top 1%. This is not hospice care. And you do not focus on the end of life. You do not get a palliative care consult when someone has 30 days to live. That is not the right way to do palliative care. We'll talk about that in just one moment. Disease management for people in the top 5%. They should all get. And by the way, palliative care is nothing but intensive disease management. It's like the ICU to the floor. It's more intensive disease management. Post-acute care. You cannot do post-acute care and do fee-for-service. Why not? Now, everybody wants to lower readmission rate enough that you don't get the 3% Medicare penalty. But why do fee-for-service and post-acute care incompatible? Because if you do this well, like St. Luke's did, they knocked down their readmission rate by 92%. And they cut out ED visits by 76%. Try that one in fee-for-service. You'll be cutting your own throat financially. You cannot do post-acute care and fee-for-service together. They're incompatible. Next one, retail medicine for healthy people with minor acute problems. People do not need an emergency room or an urgent care center if they have a minor acute problems. They want a place where they can make an appointment, go and get care for $49. Can anyone give care for $49 in an urgent care center? No, because you've got a physician there. Right, that increases the overhead cost. E-health solutions for the healthy, 50%. People who are healthy want a phone, and they want to get care when they want their care. And they may want to get their care at 4 in the morning on a Sunday, and they want it when they want it. And can you give them care when they want it? See, that's consumer. So, here's palliative care. Now, this is the World Health Organization, which I'm going to read aloud because it's got some important words in it. An approach that improves the quality of life. Doesn't say anything about dying. Patients and their families. Families are equally important to the patient. Facing the problems associated with life-threatening illness. Again, it says nothing about end of life. It says life-threatening illness, life-threatening conditions. through the prevention and relief of suffering by means of early identification. Does that say anything about dying? An impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So let me ask you a question. A 3-year-old child is now diagnosed with cystic fibrosis, a life-threatening condition. When should that child be put on palliative care? The day of diagnosis. That is when you get the benefit of palliative care. You will not get any benefit from palliative care by giving this child palliative care 30 days before their death. You will get almost no benefit whatsoever. You will get optimum benefit if you put the person on palliative care the day they are diagnosed. And there's data, ample data, to show that. Okay, so this is what you want to do with palliative care. And these are population health terms that you should all know. We're going from healthy life expectancy and quality-adjusted life years. Quality-adjusted life years is going to be a key metric in the 21st century. That's not how long you live. It's how long you live well. Let me give you an example. If I have a 50% disability at the end of my life so that I cannot do 50% of the things that I want and need to do in my life, over my last 10 years, my QALY is considered 5. In other words, I may be living 10 years, but I only get 5 years of quality-adjusted life years. LE is life expectancy, or disability-adjusted life years is DALY, and YLD is years lived with disability. So what you're trying to do in palliative care or disease management is to optimize the quality-adjusted life years. How long can a person live doing the things and experiencing the things that have meaning to them? Now, I'll give you an example. I love to climb and hike and bike and all that stuff. That's what keeps my head screwed on. I love seeing my grandson, Ari, who lives in Brooklyn. And I love seeing Ari. If I couldn't do those things and have a wonderful time with my wife, I would be a very unhappy camper. So you might think that not being able to hike is no big deal. I can do lots of other things. I can enjoy music, etc. But not hiking for me would be a very big deal. Because I have climbed mountains my entire life. It's one of my passions. It's what I love to do. And if I couldn't do that, I would not be a happy camper. Everyone has different values, and you have to check out what they are, what's important to that individual in terms of their autonomy and freedom. You have to look at someone's personal and material resources. I'll give you an example. I was an ED doc for 30 years, and I occasionally would diagnose someone with a life-threatening heart attack. I'd say, I have to admit you have a bad heart attack. He said, no, I'm going to sign out against medical advice right now. I said, what do you mean? He said, doctor, you don't understand. He said, I'm from a working class family. He said, I've spent my entire life working so my kids could have a college education and my wife wouldn't have to pay off the mortgage after I'm gone. I'm not going to give that all up just to save my own life. I did this for my family. I'm willing to die for my family if I have to. You better figure that one out as part of population health. That's the economic, non-clinical determinant. If you don't get that guy some money to support the treatment of their illness, they are not going to get treated for that illness. And people, how many of you have ever experienced anyone making a decision like that? Yeah, most of you if you thought about it. Most of you if you think about it. Negotiation, you have to negotiate, and you have to look at objectives. Now, this is a hard-to-read slide from where you are, but I will summarize it for you. This is data from 2008. It's old data, but it's the same data today. Basically, these are people on the left who lived. These are people who died. If you give palliative care to people, whether they live or die, you will decrease the cost of care per day by between 21 and 29%. You'll decrease the cost of the admission between 13 and 28%, the cost of the lab between 28 and 37%, the cost of the pharmacy between 8 and 40%, the cost of ICU care between 75 and 50%, and you'll save 78% because only less than a quarter of the people will die in ICUs. And this spaghetti chart is impossible to read, but basically every time you put someone on palliative care, the cost of care drops automatically by 35%. Because you're focusing on non-interventional goals for them to help them in their life. Now, here are the big mistakes that people make. Let's hire 2 FTEs to do palliative care. No, it's not how you do it. So let me show you how to do it. How many covered lives in your network do you take care of in terms of Medicaid? What's the total covered lives? 270,000. So what's 1% of that? 27,000, right? 2,700, excuse me. 2,700. So 2,700 is 1%. That means if you want to do palliative care among your 270,000 covered lives, you have to provide palliative care for 2,700 people. Now, how do you identify who those people are? Anybody? How do you think you identify who those 2,700 people are who are going to need palliative care? Analytics. You have to have predictive analytics, because very often it will surprise you who those people are. They may not be people who come to your office or come to your hospital or come to your clinics. They may be people who are just home sick, but they'll show up eventually when they're dying. So you need predictive analytics to identify who the top 1% is, the 2,700, and then provide palliative care for all 2,700. It should not be up to a doctor's decision. Now, doctors need to decide if we're going to provide primary palliative care to the top 1%. But once they make that decision, the system then should automatically kick in to provide palliative care services for that top 1%. Do you all see how that works? Okay. So now, you need to have aligned models in order to do this. This is disease management now. You need to have identification, and you do the same thing for disease management. Disease management is the top 5% of people with chronic conditions. How do you identify that group? Hint, same answer. Predictive analytics. Once they get into that group, you give all of them disease management, which is a team-based approach where you standardize the care and the delivery. Among the doctors and executives, you use evidence-based guidelines, empowerment of the patient. You have measurement of both clinical and business processes and analytics and outcomes, and continual reporting. So, this is the person who's going to be primarily responsible for the patient's care. The physician, I told you, is going to be a population health executive. The day-to-day care of the patient is going to be done by a care manager. How many of you use care managers overseen by physicians? Yeah. Now, what do care managers have that doctors don't have, which is why they get this kind of on-the-floor job now instead of doctors? What do care managers have? They have more time to do what? Not only speak to the patient and the family, but navigate what? The system. They know all the players in the system. They know all the payer contracts in the system. They all know all the relationships in the system, and they can help the person navigate the system, and they have analytics so they can determine who needs what and when. Okay, so these individuals, doctors are not trained to work the system. That is not something we enjoy doing. We like treating complex clinical problems. That's what we prepared to do. We like doing complex procedures, taking care of people with complex conditions. We like overseeing the system and delegating the system. We do not like working through the labyrinth that is the system. So they focus on all the functionalities, socioeconomic indicators, psychological issues, behavioral issues. They coordinate all the care between doctors and facilities, et cetera, et cetera, et cetera. You know, they say doctor's going to be captain of the team. Well, it depends. The care manager is going to coordinate day-to-day activities among people. So I want to show you how disease management works in real life, and I'm going to show you 2 disease management programs done by Intermountain and St. Luke's. So this one is for colon surgery at Intermountain. Now, why do you pick something to do disease management in? Why would you do a project in colon surgery? Why would you pick that one as opposed to everything else you could have chosen? This is Project Management 101. Of all the millions of things you could do for quality, why do you pick 1 or 2? It might be volume, but typically it's cost and it's impairing your outcomes. In other words, it's Pareto principle. You pick the thing that have the greatest impact on your cost and your quality outcomes. So they do a boatload of bowel surgery at Intermountain. It's a huge network. They do a lot of bowel surgery. So what they did is they said, doctors, we want you to review the literature and figure out the best practices with bowel surgery. We want you to scour the literature and find out what you think are the few best practices that would impact outcomes. So they said, well, you've got to get an engaged patient. early mobilization after surgery, appropriate IV fluid administration. So any of you with clinical backgrounds, what's the issue with bowel surgery and IV fluid administration? Do we typically give too much or too little? Way too little because of third space losses in the bowel. So we need to do a better job at adequately hydrating the patient. Narcotic-sparing analgesia, why is that a big deal with short-term surgeries? If you give less narcotics, what can happen? They'll ambulate sooner, they'll feed sooner, they'll drink sooner, they'll do everything sooner. And then obviously early enteral nutrition. And what you want to do is come up with measurements of those things. Now management wants to come up with operational and financial measures for each of these things. So let's go on to the next one. St. Luke's, they pick surgical site infections. Now this is kind of interesting. Why would they pick that one when if you look at the slide, their infection rate is only 1.3% with a national average of 1.9%. Why would they pick surgical site infections? Why that one? Look at the bottom part of the slide. Surgical site infection is the #1 cost of complications in surgery. If you get an infection after surgery, your costs go up by 106% on average. So that's the lowest hanging fruit. And they did some research. The doctors did research, and they said the reason why patients get infected, #1, you have traffic in and out of the OR. You have carts going in and out. #2, the ventilation system needs to be fixed. We're getting some junk through the ventilation system. #3, excessive OR time with some surgeons. How many of you measure OR times for different surgeons for commonly performed procedures? Why is that such a big deal? Doctors who operate take longer to operate. What happens with their patients? They get sicker. More OR time, more chance of infection, more anesthesia time, more chance of stuff going wrong. They have worse outcomes than doctors who are quicker. Now, you don't want the doctors to be too quick, but there's an optimum time to do each procedure. You should start measuring that. You should start measuring that. Your really slow surgeons need to speed it up. Now, some of your really fast surgeons may need to slow down a little bit, but there's an optimum time to do a procedure. You want to be careful, but you want to be also efficient. And lack of data transparency among surgeons, don't even know they're outliers because no one's measuring it for them. So let's go on. Let's see how Intermountain did. So Intermountain, what you want to do is have a control group. It's always helpful when you do disease management to have a control group to see how well this thing's actually working. So let's see how it came out. The people who enrolled in the program, their first tolerated meal was a day and a half earlier. Their first BM was a day and a half earlier. They had less vomiting. Look at this. Their average variable cost was 40% less. The average total cost was about 48% less. And the net operating income was over double, almost triple. Is everybody happy here? Patient has a better outcome. You're making more money. And you're doing the right thing with better outcomes. So the bottom line, they saved $1.2 million in this project. Length of stay decreased by almost 2 days. Everybody was happier. The patient was happier. The family was happier. Providers were happier. And the executives were happier. And what do you think they did when they got the success for bowel surgery? They started doing it for all surgery. That's what you do. You do a pilot, and if it works, then you roll it out for everybody. Okay, so let's see what happened to St. Luke's. Here's what they did. They said, here's what we're going to do to change what we're doing. We're going to have a rule that once the cart's in the room and we've started the procedure, we're closing the doors, and except in a life-threatening emergency, no carts in and no new carts out. We're going to stop all the traffic. #2, management invested in a high-grade HVAC system with a HEPA filter to increase the ventilation and the filtration in the OR. They shortened OR times through analytics, feedback, and assertive physician management. Would anyone like to define for me into English assertive physician management? Anyone want to tell me in rough English what that means? Either they got up or they got out. In other words, either they got to within the bell curve or they were told they could no longer do the procedure here. That's what it's. How many of you have ever done that around any quality metric with your doctors? Well, take a Tums and try it someday. Try it someday. Now, here's what happened. They reduced their surgical site infections from 1.3% down to 0.6%. Now, you might say, well, big deal. Multiply that by 16,000 in costs for each procedure, and they saved $4.5 million the first year. Well, Intermountain got wind of that. They started doing the same thing. This is how disease management works. You're optimizing clinical and business outcomes all at the same time. How many of you are doing anything like this in your organization right now? These types of projects with physicians and executives working together. See, this is what you need to do in the 21st century. Couple clinical with business initiatives together. They both impact each other. They impact each other. Okay, so let's get into post-acute care. I told you I'm giving you a 12-hour program in 2 hours. Post-acute care. Why do people come back to hospitals unnecessarily? What's the root cause? Non-compliance at home. Now, I'll give you an example. I told you I had my hernia fixed. Have any of you ever received IV Ativan? You know, I used to give people IV Ativan when I was an ER doc. I had no idea why people came in asking for it by name. Well, I found out 2 years ago. I was given IV Ativan by a nurse anesthetist, and I had the greatest hallucination of my life. I saw a flower exploding in my brain. And I was lying on the table naked in front of people I knew from my hometown, and I did not care. Because I saw this beautiful flower exploding in my brain. And I see the surgeon putting on his gloves, and I don't care. And the surgeon turns into my wife, because I got propofol, and said, "Would you like to go home now?" That's what I remember of my surgery. And after I got home, I said, "Did they ever discharge me from the hospital?" And she said, "They spent a half hour with you. They went through this wonderful checklist, and you signed that you understood everything." All I remember is that beautiful flower. I never even knew that I was discharged. We kid ourselves into thinking that we've done discharge planning when, according to the patient, nothing has ever taken place. See, the action with post-acute care is at home, not what you do in the hospital. Okay? Now, some things you can do in the hospital, like figure out if the patient can afford the drug. How's that to figure out in the hospital? Because they get to the pharmacy and they said, $135? No, I think I won't take the antibiotic after all. It'll probably just get better on its own. Or I won't take my Dig or my Lasix or my insulin or whatever it is. And I'll just, well, I can't afford it. I'm not going to spend $135 I don't have. We have no idea. Up to 70%, depending on the study, of people in communities never fill the prescription they're given. Yet we feel great that we've treated this person with evidence-based care. Post-acute care is figuring out everything that goes on after the... By the way, in the 21st century, nobody's getting discharged. What's happening? Transition of care. They're going from outpatient to inpatient to outpatients. Those are transitions of care. Admission and discharge implies I'm responsible now, and now I'm no longer responsible for your care. I'm discharging you from my care. We need to eliminate that. How many of you in your organization have eliminated the terminology of admission and discharge? You need to get rid of that. Those are 20th century terms. We are now doing transitions of care from inpatient out. And by the way, you're going to start getting paid for all of the care, not just what happened in the hospital. Okay, so no engagement, unable to understand discharge instructions or meds, et cetera, et cetera. No timely follow-up, 51%. By the way, they're 1,000% more likely to be readmitted when they don't get timely follow-up with anybody. Top 4 conditions, you know, et cetera. And the 3%. So, I told you I'd copy and steal everything. I copied and stole my part of this presentation from Yale New Haven, who has a great best practice. They call it transition care. They don't even call it post-discharge or post-acute. They call it transition care team. So I'm sharing how they do it with you. First of all, they have the same process in every unit every day. So how many of you have transition care rounds every day, whether it's Christmas, Easter, or Sunday? How many of you still do Monday through Friday discharge planning? You don't have to raise your hand. That's 20th century. 21st century is this is 24/7. And when should this process start? Before they come in. How many of you do preoperative risk assessment for elective procedures? Best practice. You will find all kinds of stuff like undiagnosed diabetes, undiagnosed AFib, undiagnosed apnea, undiagnosed difficult airways, et cetera, et cetera. You want to figure that out before they go into the OR, not after they come into the OR. So that stuff works. They have a team. That surprises you, doesn't it? The team is made up there of a doctor, a nurse, a risk manager, a clinical manager, a pharmacist. Who's the most important member of the team? The pharmacist. Because they're the ones who can figure out if there's drug-drug interaction, if the patient's going to be able to afford the drug, if the hospital has... Why would some hospitals want to put up the cost of the drug themselves? To save it on the back end so they don't have to pay the 3% Medicare penalty, or if they have a bundled payment or risk-based contract or value-based contract, they'll make it up on the back end so the patient comes into the ED less, comes into the hospital less, and has fewer problems. Structured interview occurs in the afternoon. Why does it occur in the afternoon and not in the morning? That's when the patient is stable. Typically in the morning, the doctors are rounding. We're checking on tests, lab tests, CT scans, et cetera, et cetera. And they do utilization review and transitions planning. Now, the whole purpose of this is they have contracts at Yale with every one of these facilities. So I'll just read them aloud because it's hard to read the screen. They have contracts with home health care, retail pharmacies, wellness centers, clinics, diagnostic imaging, urgent care, ambulatory, skilled nursing facilities, et cetera, et cetera, et cetera. Why do they need to have contracts with all those entities? Because that's where the action is once someone gets out of the hospital. So these are typical partners: outpatient facilities, federally qualified healthcare centers, nursing home, long-term cares, inpatient rehab, outpatient rehab, skilled nursing facilities, home health, employers e-health. Which of these are responsible for most of the costs? And I know there are people from these units here, so I want you to know how important you are. Which of these on this list are most responsible for outlier costs when they don't do what they do well? Which one? Not home health. Not rehab. No, not employer. Some of you work in these facilities. Skilled nursing. Let me show you. This is data from New Jersey, Florida, Pennsylvania, North Carolina, Kentucky. The blue is skilled nursing facilities. The green, the olive green, is inpatient rehab. The reddish orange is home health. And the purple is long-term care hospital. Skilled nursing facilities, number one. So at Intermountain, when they contract, well, I don't have that slide, but when they contract with a skilled nursing, they have 22 metrics that they're obligated to follow, including falls, cost of care, certification, length of stay, et cetera, et cetera, et cetera, et cetera. And if they don't meet those criteria, what does Intermountain do? They discontinue the contract. And last year they told 18 skilled nursing facilities, we can't work with you until you get your act together. But that requires at-risk contracts with each of those skilled nursing facilities and incentives for the skilled nursing facilities to do all that stuff so they can help minimize the cost, et cetera. Okay, so greatest impact is pre-acute, taking care of people at home, overseen again by a care manager, not a primary physician. Primary physicians do not do home health very often, and they don't do care coordination. They have other things to do with their time. Must have complete transparency of the entire network. At Yale, who has access to everybody's quality data in this entire network? Everybody. Everybody. And these are a preoperative risk assessment. At St. Luke's, preoperative risk assessment is done with an internist, a pediatrician, anesthesia, typically a nurse anesthetist, and a care manager. And they see 8 patients a day for 3 providers. And they do it for people with ASAs, 2s to 4s. Do you all know ASA? It's how you rate risk in surgery. It goes from 1 to 5. 1 is no risk, 5 is you're going to die, probably on the operating table. 4 is very high risk, 3 is moderate risk, and 2 is lower risk. Okay? They reduce same-day cancellations. They find obesity, sleep apnea, difficult airways, AFib, cardiac valve, diabetes, and it reduces over $1 million in costs annually net. Net reduced costs annually by picking this stuff up early rather than late. Operational goals, you need to create a network with all these providers. That's why I told the IPA you can't do post-acute care alone, because you need to work with all these post-acute care people. And you have to have analytics, you have to have clinical and business goals and objectives, you have to have standardized process, and you have to have at-risk contracts that you can modulate according to outcomes. Any questions about post-acute care? This is the crash course. Next one, consumerism. So why did patients become consumers when we were last awakened? What caused them to become consumers all of a sudden? Out-of-pocket costs, high deductible policies with healthcare savings accounts. Employers no longer give their employees healthcare. They give them what's called a defined contribution, a little stack of money in a healthcare savings account, which they can roll over tax-free. So now employees are self-employed. They cover themselves. So what 2 questions do consumers want to know before they get anything? How much is it going to cost, and is it going to work? So let me explain. So I go to my surgeon before my hernia surgery, and I said, Victor, I knew Victor because I was chief of staff when I recruited him. Victor, I said, I want you to know, he said, do you want this procedure done laparoscopically or open? I had a very complex surgery because like most good doctors, I let it go 10 years before I had it done. And I waited for it to incarcerate before I went to my doctor. That's what most good doctors would do. So I go to him and I said, this is probably a complex. This is probably both a direct and indirect hernia. It's probably going to be a little complicated. He said, do you want it open or closed? And I said, here's the deal, Victor. I'm paying for this hernia with a credit card. If it recurs through no fault of my own, I'm going to cancel my charges. And American Express is really good at working with me to support my concern if I don't get a reasonable outcome. Which way would you like to do the surgery? He said, I think I'll do it open. I said, good choice. He said, you realize bigger scar, more pain. I said, I'm fine. I'm going for the outcome. I'm not going for the scar. He said, fine. Now that's a consumer-like decision. I'll give you another example. A woman that I used to work with, her dad inadvertently had his tibial artery torn during an arthroscopy. They went to the doctor and said, I hope you're not planning on sending us a bill. They went to the hospital and said, I hope you're not planning on sending a bill. And by the way, we'd like you to sign this contract that our attorneys made up, stating that you'll take care of Dad's ankle for the rest of his life. Welcome to the 21st century. You know, they said, we don't want to take you to court. If you want to go to court, we'll go to court. But we'd rather not go to court. We'd rather just work this out with you. So if you would just agree to sign to this voluntarily, we don't have to take you to court. Welcome to the 21st century. You know, again, family being squeezed out, high deductible policies, people who are frustrated. What do consumers want? They want to know what it costs. How many of you publish your prices on your website for commonly performed things? I see one hand. It's requirement. Good. New York's ahead of the curve. By the way, they're also doing it in California, Arizona, and Oklahoma now. They want 24/7 responsiveness, market-driven as opposed to sales-driven. Now, most of our marketing departments are actually sales departments. We just call them marketing departments. We want you to get more of our stuff. That's sales. What does marketing look like? Anybody? What's the question you ask when you're doing real marketing? Any marketing people here? Huh? What do you need that you're not getting? And they say, well, we have no place to go low cost for healthcare on Sunday evening. No place in your entire system that I can see a doctor or nurse practitioner on a Sunday evening. And you build it for them. The aphorism is, when you market well, you never have to sell again. Because what you're doing is you're identifying pent-up need and you're providing it. That's a market-based solution. And by the way, people are happy to have you get reasonable margins. They know you have to have a profit in order to survive, but they want it based on real costs and not fabricated costs, and I won't get into the weeds on that. But we have this crazy thing called a charge master, and someone once, I teach finance to physicians, and they say, what's the difference between gross revenue and net revenue? I answer the question, the difference between fiction and nonfiction. Gross revenue is a totally made-up number that we pull out of an orifice that I will not describe. And net revenue is what we actually get paid. Okay, retail clinics. How many of you have either created or are working with an organization that does retail medicine? Folks, you need to get into this business. If you don't do it, it will be done to you. Because people love this stuff. You can make an appointment. It's $49. They treat you nicely. They only treat 36 high-volume, low-risk diseases, et cetera, et cetera. Mostly it's used for urgent care. But think about it this way. How many of you are in any kind of rural area of any kind? Okay. How many of you are looking for a type of specialists that you're trying to look for? We see the same hands. Where can you get the specialists today? Right here. I was working with an organization in western Nebraska, Beatrice, Nebraska. They said, we're looking desperately for a dermatologist. I gave them my phone and I said, here you go. They said, what do you mean? I said, with a 2-minute wait, you can get a dermatologist from anywhere in the country with any qualification you want, and they'll treat your patients for $49. Why do you need to recruit a human being to come and live in the beautiful community of Beatrice, Nebraska? They said, oh, well, I think our doctors still want to recruit. Well, some people are stuck in the 20th century. You can get any specialist 24/7 on your phone right now. Why do you need to recruit someone when a dermatologist needs to look at rashes? And you can see those rashes beautifully on a smartphone. Take a history, et cetera, et cetera. So it's great for rural care. It's great for providing gaps in coverage, behavioral health, home health. Someone can't go to the doctor's office. They can get their phone. And you can even give them a phone. And they can get home health on their phone while they're at home. They don't have to go in an ambulance. They don't have to go in a transfer vehicle, et cetera, et cetera. So who do you have to work with in pop health? You've got to work with your doctors, got to work with payers and employers through dynamic contracts, and even your competitors. So I'm going to show you a little bit about analytics. Analytics, as the gentleman mentioned, is not reactive. It's proactive. It's current. It's transparent, unblinded, and you're managing, predicting, and redesigning. So you want predictive analytics, and let me show you what analytics looks like. Again, this is almost impossible to read, so I will interpret it for you. This is from the Mayo Clinic. These are all their service lines. It's got from high volume to low volume, average length of stay, case mix index, total charges, actual payment, variable cost, contribution margin, fixed cost, and net income. You notice that pulmonary is their second most common service line, only makes a net income of $865. So let's click on that. You get all the DRGs from pulmonary. Most common is pneumonia. Pneumonia patients were only making $492 per patient. That's very, very low. Let's click on that. This is where it gets really fun. Here's 10 different doctors at the Mayo Clinic treating the same diagnosis. Doctor number 3 makes a profit of $3,840 net on every pneumonia he treats or she treats. Doctor number 2 has a loss of $4,110 on every case of pneumonia that he or she treats. How do you lose $4,000 treating a pneumonia? Anybody? Length of stay is too long. What else? Wrong. Too many tests. What else? Non-formulary drugs. What else? Poor compliance. What else? Lousy documentation. It goes on and on and on and on. How many of you can measure this in real time right now and can give your doctors the feedback right now? Folks, every other industry in the world does this, and 700 healthcare organizations have this technology right now. It's called cost accounting. You need it tomorrow. Forget about your budget. You don't need a budget for this. Why? You can lease it for relatively low cost. What do you think the payback period is for analytics for cost accounting? Under 30 days. Why? You can go after your low-hanging fruit because you know where your low-hanging fruit is. You can identify your low-hanging. Folks, you've got to get these 21st century tools. You're no longer in the 20th century. You've got to have these tools so you can do your job. This is what we need to do to be managers today, real time. What's the lag time when you know whether you have cost outliers or not? What's your lag time right now between when the cost is incurred and when you know about it? Anybody? How many is it 30 days or less? 60 days or less? Some of you don't even know. That's even better. You can't manage something you can't measure. Peter Drucker, 1954, Management by Objective. If you don't measure it, you can't manage it. If you can't manage it, you can't improve it. You got to be able to manage. You got to be able to measure this stuff. You got to be able to do your job. I once got offered a chief medical officer job, and I said, "Do you have analytics, or do you have any plan to get them this year?" He said, "No." Then I said, "Then I cannot accept your job. I cannot be held accountable for something I can't manage or measure." The CEO was shocked. He said, "But this is a really good, high-paying job." I said, "That's great, except I want to be able to do my job and do it really, really well. I need the tools of the 21st century to do it. And I really suggest you strongly recommend that you consider getting these tools so your entire management team can do its job." This is how to do work in the 21st century. Okay, so how do you contract for pop health? Well, this should be review now. You identify a population of covered lives. In your case, it's Medicaid, it can be Medicare, it can be commercial payers, it can be anything. Develop clinical and business analytics to assess financial risk. You have to measure which subpopulation they're in. So you can separate the 1% from the 5% from the 50%. Risk stratify all covered lives into functional subpopulations. Develop a clinical and business plan for each group. Each group needs a different business plan and a different care plan. I do not need annual visits to my doctor's office. I'm sorry, but I don't need that. What I need is a smartphone, I need an app, and I need retail clinics. That's all I need. I will get surgery 60 years from now, and I will get hospitalized maybe shortly before my death, but I don't need anything else. People in the top 1% need far more than you're giving them. They need palliative care. All of them, all the top 1% need palliative care the moment they're diagnosed, and the people in the top 5% need disease management. So this came out of the Mayo Clinic in 2012, but this is basically from their predictive analytics. They discovered 3% of their population. This was only a cost of $54,000, much lower risk population, $14,007, so they risk stratified them. Okay, now what you want to do is have a plan for each of these groups. People in the top 1%, we're going to get palliative care, intensive disease management, home health, multiple chronic diseases, disease management, at risk, medical home, nurse navigator, healthy, telehealth, etc. Now, what Geisinger has shown us, because they're heavily invested in population health, is that different interventions take different periods of time. Which investment will get the greatest return on investment the quicker? Telehealth and treating healthy people, or palliative care? Palliative care, that's your greatest return, whether you're in fee-for-service or not. This is predictive analytics at the Mayo Clinic. It shows they were shocked to find out that 50% of their employee health was ENT for dependents of their employees. They had no idea. By the way, if you get predictive analytics, you'll find stuff you never expected. Who wants to give me the root cause of why 50% of their costs are kids with ENT problems, ear, nose, and throat problems? What's the root cause of that? Smoking. Smoking at home. So they sent out a whole team to deal with their employees who were smokers. And they were able to save a huge chunk of their employee health costs. Again, this is using predictive analytics to figure it out. The second group, by the way, is dermatology for dependents, which comes out to acne. What's the number one cause of acne? Why do some teenagers get more acne than other teenagers? Sugar, diet, junk food. So they sent out a nutritionist to help kids learn how to eat right when they're teenagers, and the families just serve them foods. Get rid of the Fruit Loops, folks. Get rid of the Fruit Loops. Okay, so how do you move from fee-for-service to risk-based contracting? You've got to align first, build the network together, work on labor and supply chain. That's a whole talk in itself. Palliative care is the first thing you can do because you will save a boatload of money under fee-for-service. That you can do in fee-for-service. You want to do inpatient disease management first because you can do all that and save a boatload under fee-for-service. Then grow new sources of revenue. You can't just cut costs. Lean and Six Sigma are fine. But as long as you're cutting costs, it's the snake eating its tail. You'll eventually cut into your revenue stream. You eventually have to grow new sources of revenue. That's e-health, Domestic medical international tourism, I could talk for hours on that. Focus factories and solution shops. Then, when you're moving out of fee-for-service, grow the ambulatory population health. Do not do post-acute care until you're out of fee-for-service, because you will cut your own throat. Can't be done. And then you want to develop ambulatory disease management, retail and home health, and then exit fee-for-service last. So I'm going to leave you with a final thought. You cannot cut your way to success. I see so many organizations, they say, what are you doing for healthcare reform? We're cutting costs. Good, you're destroying your business. You can't do that. Build a new clinically integrated enterprise based on cost-effective health. By the way, the health industry is going up to $5 trillion from $3 trillion. Who's going to pay for the other $2 trillion? Healthy people like us out of our own pocket. I go hiking and biking and climbing because it's good for me and it makes me feel good. I fly every 2 months to see my grandson because it's good for me, and I hope good for him eventually. But right now it's just good for me, and I'm having fun. So I go to see my grandson. I spend out of pocket for my own health. Quality-adjusted life years rather than life years, patients and consumers rather than providers and enterprise. The 20th century was all about the hospital and the doctor. The 21st century is going to be about patients and consumers. By the way, how do you tell a patient consumer whether they're horizontal or vertical? If a person is vertical, they are a consumer. If they're horizontal and they're unconscious, they're a patient. By the way, 15% of encounters are with patients, 85% are with consumers. Consumers require a clinical and a service diagnosis. Patients just need a good clinical diagnosis. That's a longer talk, but I'll leave you with that. Rather than providers and enterprise, and you'll be far more likely to succeed. I think this is a great time to be in healthcare. Osler, who was the great internist from Johns Hopkins, told his residents and interns, he said, I feel sorry for you. He said, my generation invented the organized medical staff. We invented the hospital, the teaching hospital, the laboratory, the sterile OR. We invented all this stuff that you will have to take and run with and modify over time. You get to design and be the architects of the new healthcare delivery system in America. And depending on how innovative you are, you will create models that other consultants like me and other organizations around the world can copy. Thank you so much for all your time, and I hope you have a wonderful conference. Thank you. Any final questions? Any final questions from anybody? Covered a huge amount of ground. Yes, ma'am. My orthopedist. Internist.
So when you talk about population health, right? So when you talk about population health, what do you say to these hospital-based ambulatory clinics? Like, is it the board understanding what population health is? How do you get them to move in that direction? Because they're still very fee-for-service.
Okay, everybody has to know the why before they do the what. So they first have to get the rationale, why do we have to change? We're comfortable here. We make money doing fee-for-service. This is how we make our living. This is the model we grew up and we know and love. Why should we change and go out of our comfort zone to do something very uncomfortable, to learn new things, learn new skills, have to come up with an entirely different way of doing it? Until they understand the why, you can't get them. You have to educate them first as to why the world is churning, why it's not going back, and why it's in their self-interest to want to change. Until someone gets into the WIIFM, you all know that radio station? What's in it for me? Until someone turns on that radio station, what's in it for me? They will do nothing. And they will do nothing but resist change. And they'll go to every meeting to resist change. So everyone has to feel that I have a stake for me and my family in making these painful changes so we can provide better care at lower costs and get paid differently. Until you can get them to that point, you can't go anywhere. So this is a process. I call it moving the elephant across the room. In order to move, that's change management. In order to move the elephant across the room, the elephant has to see that there's better food across the room than there is here. And if you can, remember Paul Convery, the exercise you and I did? Paul Convery helped, by the way, his first year, he signed 1,800 contracts. And he was paid $500,000 then as chief medical officer. He increased Baylor's incremental revenues by $1 billion his first year. I'd say that was cost-effective management. But the point is, he had to go and speak to those doctors one-on-one individually to show them why it was in their self-interest to work with Baylor and not because it would be good for the community. You have to talk about WIIFM, and the doctors did it for themselves, and then they realized that it was better for their patient. So you have to kind of start low in Maslow's hierarchy of needs and work your way up, but start with why is this good for you to make these changes. Once you can get there, then you can get them on board to not only do it, but even to lead it. Human beings are pretty predictable. We're survivors, and we want to take care of our family. You have to realign incentives, which is why work RVUs are so destructive. Work RVUs keep us in the past. How many of you are working to get out of work RVUs as your primary reimbursement model? Please, pretty please with sugar on top. Get out of work RVUs should be basically increments that you measure to give people bonuses based on productivity. It should not be the primary method of payment, or otherwise your doctors will never be paid to keep people healthy. They will be paid to do procedures, and the higher the procedure, the more complex the procedure, the more they get paid. It's a terrible way to pay people. Any other questions? Yes, sir. Let me come over. I want to bring the mic.
Thank you. A lot of us are getting ready for value-based payments, right? And the transition from fee-for-service to value-based payments. And as I looked at a lot of the risk-based contracts that you talked about during the presentation, that sounds a lot like full capitation, where there's like, not initially, right? So I guess one of the questions is, do you think that's where things are going? That like value-based payments are more of a warm-up to eventually taking on even more risk?
Yeah, I absolutely agree with that. This is a journey. And by the way, integrated networks, or doing clinical integration, as we talked last night, is a competency. It's not a payment model, and it's not a structure like an accountable care organization or patient-centered medical home. People are doing bundled payments to learn how to do fee-for-service with a lower cost structure. These payment models, the purpose of these intermediary payment models is to learn how to do things differently. In other words, how many of you are doing any type of bundle payment project at all? When you do bundle payments with your specialists, what you're learning to do is working together using analytics or measurement tools, working on supply chain and vendors. In other words, you're learning new skills. And the whole purpose of this, we're eventually going to get to some form of capitated, risk-based contracting, total contract, like Maryland, like California, like what Kaiser Permanente. That's where we're heading. That's the final destination. But we have to go through transition to get there, because most people cannot flip a switch and just go from one to the other. It's impossible. So you need to transition your business plan and do it incrementally. And you should all go back and have a 3 to 5 year plan, or how are we going to go from point A to point B, and what are the intermediate steps we're going to want to take in order to get there safely. Because you want to make a profit while you're doing this, and you want to take good care of your patients, both at the same time. And the two are not mutually exclusive, but they require different payment models in order to do that well. And you want to be able to, by the way, for those of you in Medicare contracting, there are 90 different ways to get paid under Medicare now, and almost as many ways to get paid under managed Medicaid. So you want to work with the payers to figure out new innovative ways of doing it before you have to do it. Do not wait until your arm is twisted behind your back to do this stuff, because then you'll be forced to do it their way, not your way. If you do it voluntarily, you can work with the payers to create your own models that work for everybody. And that's why you want to be a leader, not a follower. Leaders get to set the rules. Followers have to follow the rules. So I encourage you to embrace these new models, not to push them away. Any other questions? Well, thank you all very much. I really appreciate your time.
Thank you, sir. Thank you so much. So you guys really got a great interactive, full of knowledge presentation. Dr. Burroughs, thank you very much. Now, on your agenda, you have a power break. 10 minutes. I want you to know, during that time, look at your sheet. You have a Get Social sheet in your package. When you are sharing